Okay. I want to welcome everybody to Pediatric Grand Rounds. It's my pleasure to introduce today's speakers who will provide an update on the historic multi-billion-dollar transformation of California's behavioral health system, an initiative that will affect all of us as providers. We are joined by two UCSF pediatricians at the forefront of this work. Dr. Sohil Sud is a practicing pediatrician on our faculty and serves as the director of the entire Children and Youth Behavioral Health Initiative. Dr. Joan Jeung, did I say that right, Joan? Sorry. Jeung, from our Division of Developmental Medicine, serves as the Senior Associate Director for the new CalMap Access Portal. Today, they will discuss the statewide vision for this new ecosystem and review resources designed to help us integrate behavioral health into our daily practice. Please join me in welcoming Dr. Sud and Dr. Jeung.
All right. Do you mind? Should you do the intro first, or I just jump in? Good afternoon, everybody. Good to see some familiar faces in the room, and really a pleasure to be here with you all. As Roberta mentioned, a bit of a homecoming for me. This is where I train. This is where I grew up professionally. And this is where I owe a lot in terms of like the friends and the mentors and the colleagues and everything. For those online and those in the room who are interested in taking your clinical training and moving to a policy space, I am very happy to be a mentor or someone to chat with about these types of pieces. As I've learned, it's actually the framework's pretty much the same. You take your subjective input, you take your objective data, you create an assessment and then a plan. And then you learn about how that plan went and you revise it over and over again. So that's what I do day to day. Just now a little bit more with meetings and emails than in a clinical room, but those principles still hold true. Well, we are here, Joanne and I, to talk about something that's that I would argue is probably impacting all of you in your professional realm and many of you potentially in your personal realm, which is the troubling reality of the fact that it is probably harder now to be a young person in society than it's ever been, right? There is so much thrown at young people these days. You talk about polarization, you talk about the rapidity of data coming at them or inputs coming at them, their community from being a family or a geographic terrain to the entire world in many respects. There's a lot happening. And it shows up in terms of the stresses and the data, right? So on the far left here, you can see that while children do not die, fortunately, very frequently at all in the state of California and in the United States, suicide is one of their top leading causes of death, right? So depending on exactly how you parse out the data, if you're looking at 10 to 24-year-olds, it's essentially the second or the third leading cause of death. And if we say that's unacceptable, then we shouldn't accept it, right? We should do more to do better there. And while it is an issue in youth, these youth, as you pediatricians know, they grow up, right? If you take a life course approach to this, you can see in the second and the third point here, youth who have clinical levels of anxiety and depression and mental health and substance use issues, they go on to have lifelong problems, or at least a risk of increased lifelong problems in the health side, in the financial side, in the social side, and the legal side. So many aspects of their life can be impacted by this. The second bullet, which says adults who had a childhood mental health disorder have 6 times the response. The third item here says adults who've had impaired functioning have a 3 times odds of increased adverse outcomes. Impaired functioning means subclinical, essentially, right? So still having some degree of anxiety and depression that hasn't been clinically diagnosed, but is there. And these are longitudinal studies that have showed this. So whether you see this in your exam room as an oncologist or a cardiothoracic surgeon or a general pediatrician, many youth are impacted either at the clinical level or subclinical level. So I would really say it's incumbent upon all of us to keep an eye on this. And the last point here is probably the most important, is that this is a pediatric condition, right? The most frequent age to be diagnosed with anxiety is age 15. The most frequent age to be diagnosed with depression is age 20. So these things are emerging while they're in our care before we hand them over to our adult physician colleagues. And early intervention works. It's evidence-based. You're going to hear a lot about that throughout this time period. And we all need to keep that in our mind. Prevention and early intervention is the name of the game here. So what do we do about these issues? As Roberta mentioned, California is really leaning in to make a difference here. And a lot of that work is happening through this initiative, which is called the Children and Youth Behavioral Health Initiative, CYBHI. And it's a more than $4 billion state investment. So it's your tax dollars at work to change the game and to transform the way we support children, youth, and families. And part of that effort is reforming the healthcare system. And we're going to spend some time today really celebrating the partnerships between the state of California and UCSF and the great work that's happening to transform the clinical environment in so many different ways. But we also have to meet kids where their lives are lived, and they don't live in the clinic, right? They live in homes, they live in communities, they live in schools, in childcares, in colleges, and they live online. I think everywhere I go, I ask people to raise their hands if they do not have a smartphone on them at this moment. And I've yet to see a hand go up. This is a hybrid meeting, right? Like we have to meet people where they are. And while I would love to talk about all of this with you, again, today we'll celebrate. Oh, sorry, before we focus much more on the medical partnerships, I did want to bring it home here to San Francisco, where we are today. So if you look across all of those sectors, these are the types of funded partnerships and efforts that are happening in this county at this moment in time. So, I'm definitely not going to go through all these, but the new partial hospitalization program that's being built at San Francisco General is part of this effort. The idea of expanding psychiatry, mental health nurse practitioners so that each year more and more graduate from this institution is part of this network. Working with San Francisco State to expand their social work program. So a lot happening in the healthcare setting and a lot of relationships and partnerships with UCSF and the General and San Francisco Department of Public Health on that. Efforts happening in the schools that your kids go to and your patients go to through San Francisco Unified, through UCSF, right? We are a medical school. And so a lot of the students here are getting support through this effort as well. And the homes and community side. We know we need a bigger workforce, and that workforce needs to be in places where kids spend their time. And so you can take a look at all of the different community organizations that are partnered with us, that are scaling their abilities to support kids with mental health and substance use services through the various partnerships here. So you take all of those local supports here in this county combined with some of the statewide supports. This is the scale of change that's underway here in San Francisco as one example. None of this is secret. So if you ever want to find out, partners, awards, any of those places, there's a website we can direct you to where you can search and you can learn more about what's happening. If you live in Alameda, if you live in Santa Clara, you can do the same and continue to search and partner with your organizations because we work better when we work better together. And with that, I'm going to pass to Joanne to talk a lot more about one of the exciting partnerships that's underway here to really support the primary care workforce and the general pediatrician.
Yeah. So I am actually a general pediatrician in the Division of Developmental Medicine right here, just walk down from the Frisco building. But before I came to UCSF, I worked at a federally qualified health center doing general pediatrics in Oakland for about a decade. And while I was there, I encountered a lot of kids with mental health issues and often felt like need help, need more training, definitely need some coaching. And this is what's being provided in this new program called CalMap. I don't know how many of you guys had heard of CAP, the Child and Adolescent Psychiatry Portal. This is the same program, but kind of under new rebranding now that we have become part of the Children and Youth Behavioral Health Initiative and got the funding to go statewide. We are now called CalMap. It's the same program. And so this is the reason why a program like CalMap is needed. For those of us looking for psychiatrists and other mental health specialists to see our patients with mental health needs, those areas in red are actually where there are 0 child and adolescent psychiatrists. The areas in orange are high severity shortage, kind of, and you can see that's most of the state. Very few green areas where there's kind of sort of enough psychiatrists to go around. But even here in San Francisco, we're green, right? So it's still not easy here. Think about the rest of the state. So in this workforce shortage, right, where there aren't enough specialists to go around, how do we go about meeting the need that's out there, this youth mental health crisis that we're encountering? One idea is really to mobilize primary care providers to train, equip, and support primary care providers to be providing more of this mental health care. Because long before anybody ever gets sent to a psychiatrist, they might be that anxious kid in your clinic, right? They might be having some early behavior problems. And so we as primary care providers are really well positioned to recognize the issues early, to intervene early before the early problems become much bigger ones that can potentially derail their whole life, right? So we've got that trust as primary care providers. We've got this longitudinal relationship with the families. And so those are the things that we can really leverage as we're talking about these really impactful but also sensitive issues like mental health. And the fact is, because there's such a shortage, not just here in California, but across the country, growing number of primary care providers are actually stepping in to provide a lot of this mental health care. I want to argue that this is actually a core part of our job as pediatricians. Now, I'm old enough to have come up through residency at a time where I did not learn how to prescribe SSRIs. We were just told there's a black box warning, and this is not our job as pediatricians. We shouldn't be doing this. And so it was only when I had patients coming to me crying and shaking, and just saying, I'm falling apart now. I need help now. Where can I get help, right? This is what started motivating me. I need to get training. I need to learn how to manage this. And then when you dig into the numbers here, right? Like compared to a lot of what we call these bread and butter kind of conditions like asthma, we wouldn't think much of a pediatric residency that graduated folks who didn't know how to diagnose and treat asthma. But look at the prevalence here for ADHD. It's higher. The prevalence for anxiety, it's even higher than it is for asthma. There's just so many kids who are impacted. We just have to start thinking of mental health as a core part of what we do in pediatrics. This is actually part of our job. And the fact is that the American Academy of Pediatrics, they put out this policy statement, these mental health competencies that specifically call this out and saying that mental health is health, and that we need to be able to recognize and manage a lot of the more common behavioral health conditions in children. So this actually came from the AAP2, and their most recent survey of like a couple cohorts of pediatric residents that have graduated. So 80% of our colleagues out there in the country are saying mental health is a big deal. It's a huge issue facing our patients. 20% say they see kids with suicidal ideation once a week or more. Okay, huge level of need. I'm sure many of us can attest to that we are seeing in our clinics, in our practices. I can't believe it's this low, but 25% said it was very difficult. This was the maximum level of difficulty. Okay, there's somewhat difficult. This is the very difficult category. And increasingly, as I said, primary care providers are getting into the work of prescribing psychotropic medication because we have to, but only 10% say they're actually really comfortable doing this. So we are in the mental health workforce, but we need support. So this is where these programs come in. Child psychiatry access portals, also known as pediatric mental health care access programs. This is actually a model that got first developed in Massachusetts about 20 years ago and has since spread. But it is an increasingly evidence-based model with multiple components. It's fundamentally a workforce development program. Okay? So training primary care providers to recognize and to manage the common behavioral health conditions. We do it through multiple components that are very closely related, right? So in addition to like what you would think of, CME, continuing medical education, training, that's a huge part of what CPAPs do, in part to develop some confidence, to develop some skills, right? But then in addition to that sort of like lecture and that CME, there's that one-on-one coaching that needs to happen. Say, hey, my first time starting an SSRI, I needed a psychiatrist to walk that through me because, get me over that fear of the black box warning. And so this is where consultation comes in. So all the CPAPs offer almost real-time telephone curbside consultation with a child and adolescent psychiatrist. So this is not a direct patient consultation, okay? This is a primary care provider calling for a curbside consult with a psychiatrist and saying, I've got this kid, not sure what to do. Can you please help walk me through what good next steps might be to care for this patient? This is a really important part, again, of that workforce development and training primary care providers to do, again, the work for these super common behavioral health conditions in pediatrics. Now, as time went, we realized it's not enough to say, oh, this kid needs cognitive behavioral therapy. The families and the pediatricians need help finding said cognitive behavioral therapists in the community. And so care coordination, resource navigation became another core component of this PMHCA or CPAP model. And just collating resources, all kinds of resources that can give directly to families, to children, but also to their primary care providers to help meet the mental health need in primary care. So this is an evidence-based model. So 20 years now of national experience in providing programs like this across the country. So 2019 RAND study showed that children in states that had programs like this were significantly more likely to receive mental health services, any kind of mental health help, than children in states without these programs. And as of 2019, it might have been about a third to half the country that had programs like this, right? So this is a pretty good comparison. And in those states that had these programs, for kids with moderate to high PHQ-9 scores indicating potential depression, they were much more likely to get timely evidence-based care if their primary care provider had actually consulted one of these CPAP programs. So this brings more evidence-based, timely, effective care into the lives of children. It's been shown. And so there is a national network of CPAPs or NNCPAP where some of these studies can be found. And this is a nationally scaled model. So all the places you see here in light blue have a full CPAP or PMHCA, okay, including us. Okay, thank you. And then that dark blue Pennsylvania means it's a partial program. And I heard Idaho just became the 50th state that put one of these. So CalMap, we are the PMHCA or the CPAP for California. And thanks to funding through the CYBHI, we can now be statewide. We started out just providing telephone consultation to pediatric primary care providers kind of locally in the Bay Area. And little bit by little bit, we got grants from HRSA, the federal government, and now from the state. And so we can be statewide. We serve youth ages 0 to 25 or the primary care providers that see them. And we provide that telephone consultation, that curbside consult with a child and adolescent psychiatrist, e-consults as well. So we can get those consultations through e-consult format. We also offer a pretty rigorous CME program as well. So we have a lot of training that's available, and I'll go through some of the details, as well as help with resource navigation and care coordination. So we offer all these things that are really part of that PMHCA or CPAP model. And we being California, we like to push the envelope a little bit. So we're pushing the e-consult out a little bit more too, so that you can do this 24/7. We, in addition to being able to consult with a psychiatrist, you can also consult with psychologists. So we have autism psychologist experts. So if you want to be able to talk with one of them about like, what do I do for in care for my autistic patient, et cetera, we have an adolescent substance use disorder specialist as well. So you can consult with our psychologist with this very specialized expertise, as well as with the child and adolescent psychiatrist. In terms of CME, we offered over 50 hours of free CME related to pediatric mental health last year. And some residencies have actually started using our recordings as part of their mental health curriculum, because we have aligned all our CME with the new ACGME pediatric residency requirements for mental health training. So it's aligned with that. And we have aligned with the American Academy of Pediatrics mental health competencies for pediatricians. So these things are closely aligned. We are increasingly working with residency programs, pediatrics, and also family medicine residencies across the state to get trainees up to speed on this too. We also have a lot of resources on our website. So if you're looking for that medication tip sheet with starting doses, titration, common side effects, etc., they're available on our website as well. Clinical pathways, lots of tools for just really busy primary care providers to try and get this care to patients. We also have some family-facing resources also. We often don't have time to give all that guidance we want to be in the office visit. Said, here's a QR code, scan this, check out this video, I think you'll like it. So we have a lot of these family-facing, youth-facing resources as well. I don't know if we have time at this point for a video. I don't think we, yeah, okay.
So as the patient's primary care pediatrician, we're often addressing all the mental, physical health concerns that come up in the clinic. And kids these days are really struggling. It's tough to be a kid right now.
The need for mental health services right now, we know, have been growing for decades. We simply don't have enough specialists to meet the need in any kind of current traditional care model. But pediatric primary care providers, they're often the first ones to see concerns. And CalMAP aims to improve primary care providers' knowledge, skills, and confidence in treating and managing common mental health conditions. CalMAP is California's child psychiatry access program, and CalMAP offers free statewide consultation to pediatric primary care providers in real time when they're seeing a patient. And it's available to all primary care providers across California caring for California youth age 0 to 25.
Many of us primary care providers were not trained in pediatric mental health. So CalMAP provides the advice and the training to be able to manage more of these common behavioral health conditions within their own practice.
CalMAP has been monumental in terms of access and like elevating a family's priorities and their ability to receive care from an equitable and fair place.
When a challenging case comes up in clinic, I know they're only a phone call away or an e-consult away. It just gives me more comfort in walking into that clinical space when you never know what concerns are going to come up in the primary care setting. Being able to access a psychiatrist, talk to them, talk through some of the plans for management, and being able to carry those out with the patient has been really meaningful and rewarding.
The goal is that across the state of California, providers that are seeing children can receive this consultation and build their capacity in addressing common mental health needs. And if you think about how many thousands of children a pediatrician will treat over the course of their careers, that's many, many lives that are impacted.
We cannot say we are caring for the health needs of our pediatric patients unless we're addressing mental health as well. And through CalMAP, we can bring help and we can change lives, and sometimes we can save them. Because that is what's at stake, right? We can change lives. So this has been our footprint. Since we first started as CAP through some philanthropy dollars in the local Bay Area, late in 2019, we now serve close to almost 4,000 primary care providers across the state. We've had over 6,600 consults on over 4,000 unique lives. And this is growing, and especially as we got kind of the funding and the support to kind of go statewide. It's been exciting to see this rapid growth. So as I said, curbside consultations Monday through Friday, 8:30 to 5 p.m. by phone. You can specify a callback time, or if you're charting after hours, as many of us are, and you realize I had this question, you can send an e-consult and get a written reply back within a business day, working day. You can also send those consults to care coordinators and saying, I am looking for a CBT therapist or a trauma-informed therapist in this county who takes this insurance. Who can you help find for me? And you can send that as an e-consult, and they'll research, they'll double check to make sure that place is like up and running, and they'll send those recommendations back to you. Occasionally, if this is a more complex patient, you can also do telephone consults with care coordinators also. So there's a lot of stuff that they might need, and we can talk through with you, like what might be available in that area. So this is the QR code if you want to get this into your phone right now. That's also the phone number. Phone also works. Okay, so I mentioned we have a lot of CME, and this was something that we feel is a very important core part of what we do in workforce development, right? In really getting primary care providers knowledgeable, skilled, and confident in meeting mental health needs in their patients. So last year, we offered over 50 hours of CME credit. Some of this was through live webinars. We have case-based discussion. That's called Project Echo. We have an Echo for school-based providers as well. This year we've started doing more live in-person regional trainings, and these are things we call boot camps. We had one actually right on the corner at the Pritzker building earlier in September this year. So you could go live in front of people and ask. It's sometimes easier just to learn in person that way, right? You can ask the questions right there. But we also know that not everybody can show up live either to a webinar or to a boot camp. So we have a bunch of recordings available online. And then so you can actually go onto the UCSF CME site and access these recordings, answer a bunch of CME questions, and get CME and American Board of Pediatrics MOC Part 2 credit. We have 18 hours worth of online credit available that way. And for those who invest the time to learn about these 6 core topics, ADHD, depression, anxiety, autism, triaging suicidal risk in primary care, and the safe use of SSRIs, we give you this little like core badge. I think it's kind of cute. These are some of our upcoming training topics. And as I said, we align with the AAP, mental health competencies. And so we're increasingly taking, I think, a developmental perspective on mental health as well as a series of skills to be learned and not just disorders to be treated. And that's very much in line with how the AAP conceptualizes mental health. These are some of the boot camps we've done recently or that we're about to do. We did one here, did one in Riverside and down in Orange County, hoping to do more across the state. I want to bring up our website because a lot of people have found, hey, I need that Vanderbilt. Where can I find it? It's on our website. If you want like other behavioral screening tools that are evidence-based, they're there as well. And the medication guides, but we also have a lot for families. So we have this list of like videos that kids can go see, that parents can go watch if you don't have time to do the guidance yourself in the clinic. So definitely check that out. This is one on online behavior management resources that I turn to a lot, right? Like those behavior concerns come up and you don't have time to sit through and talk about all the ABCs of behavior management there. Say, go watch these videos. Okay, so the care coordination, I talked a little bit about it in terms of being able to do the e-consults and the direct consults, phone consults with a primary care provider. Once in a while, just because you're an internal audience, I will say we can do a little bit of hands-on care coordination too, but don't make that too widely known, as well as all the self-serve resources. Okay. All of this takes time, and we know physician time is very, very valuable. And we are all under the gun, right, for being like clinically productive. So there are ways in which you can add time to your same day like CBT codes so that you can get paid. You can add the time of that CalMet consult to the total time spent for the care of the patient and bill at a higher level. This is one way in which we can sustain this work and make this sustainable for us in the long term. I think we're all familiar with those CPT codes, right? We use those every day for our E&M codes. But if you do this consultation on a different day, right? A lot of people like to do this on an admin day when they're not running from patient to patient. And you call on then you can bill a separate day consultation code. And I think it's 99452 for interprofessional telephone consultation. So this is another way in which you can get reimbursed for your time. And for those of you listening who might be at the general or at children's, you're in an FQHC and time-based billing doesn't work, this code should work for FQHCs too. So consult on a different day, get paid for a different counter. Okay. So I want to make the point that a single consultation on a single patient may not seem like that big a deal, but there's a real ripple effect from that consultation. And I'll use my own self as an example here. First time I used SSRIs, I had to consult a psychiatrist maybe like 2-3 times on that patient, right? It's like, now what? And now what? And I went through a lot of CME, and then like, how many times have I actually done this now with a lot more confidence, didn't consult anybody? And we found this to be the case for many of our early adopters. There was a period where they were calling in a little bit more often, but then they say, we've got this, we know how to do this now. So they're actually not calling in as much because they've actually become more confident with these skills. So there's a ripple effect from the early consultations to later care. Okay. And so think about it. If the average pediatrician sees 1,800 patients in their panel, that is a huge potential ripple effect from a few consultations. And so this is like what the survey data says about our users in terms of like the impact of using the service on their own clinical practice. So half said, yeah, we're definitely using these screening tools more often. We feel more confident in the diagnosis. And not just the meds, but non-pharmacological interventions as well. We feel a lot more confident in all of this. These are some of the quotes. I'm just like going to share what some of our users have said. Okay, and over 50% of those who call in, like for consultations, end up being able to keep these kids in primary care, and that reserves specialty capacity for the kids with the really complex needs, right? So imagine if we sent every single kid with wheezing to the pulmonologist. What would happen to those pulmonologists? And what would happen to the poor kids with CF and like all the other kind of more specialized conditions who actually need that pulmonologist care? We can do the same thing in reserving psychiatry capacity for the more complex kids and keep the garden variety ADHD and depression and anxiety for ourselves. This is a support service. One of the best things about it for me, because I not only work for it, I also use it. It's that I don't have to feel alone in making some tough clinical decisions about kids with some pretty serious mental health needs. I can talk this over with somebody. I have the backup. I have a lot more confidence in it. And that does help to reduce burnout. Because one of the causes of burnout is like when you see a need and you feel kind of helpless to address it. This is a real way to help bring more effective care right there to the bedside. And so you just feel better about the care that you're providing. A couple more quotes from some of our users here. I think really speaking to the increased confidence and skill that people feel when they start making these calls, participating in our CME, and feeling like more confident in addressing mental health needs in primary care. No call too small. So I had a pediatrician from San Francisco, let's just say, well-established person, well-known, walk into our first project deck and saying, we all feel like interns again. We didn't learn to do this in residency. And it was quite an admission coming from somebody just of her stature and really, really struck me. Okay, no call too small, right? And the idea is that together as a team, we can bring the help to the kids when they need it, so they don't become those adults with those poor outcomes. Like they don't become that youth whose life is derailed because that mental health issue was not treated on time.
And then this may be the most important slide, actually. So this is where you go to register as a clinician to start to be able to provide those e-consults and get into the system to be able to work with Joanne and the amazing team at CalMap. I'm trying to picture, what if the general surgeons had a tagline, "No call is too small," right? That's the ask here, right? Is don't overthink it. If you're concerned, if you're not sure how to manage the patient, instead of referring them for a 5-week, 5-month in some cases line, make the call. And in more than half of the time, it seems like you're able to keep that patient with you. So thank you so much, Joanne. And I hope folks are thinking of questions. We'll take questions at the end here. I want to transition from that to another partnership we have with UCSF that is complementary and really synergistic, which is the idea, and I know this is shocking to all of you, but babies don't go to the doctor by themselves, right? They come with somebody who's a little bit older in age, who sometimes has a lot going on themselves, whether that's the parent, the grandparent, the foster parent, somebody in their life who is caring for them. Life isn't always great for the adults in that space, right? So in terms of systems changes and systems reforms, one is to really ensure every primary care provider has access on the phone or digitally to a child psychiatrist, a psychologist, a care coordinator. But another one is to transform that clinical environment, that primary care environment altogether, which is to integrate care for the child and that caregiver in the same place at the same time. And the idea behind it is pretty simple, right? Kids see the doctor a lot, especially in those first 3 years of life. Adults don't see their own doctor nearly this much on average, right? So all of these are opportunities to care for that child and care for that caregiver in an integrated fashion. That's important for both, but also the second point here is that 0 to 3 age, like these age where these visits are happening, is such a pivotal and important time in the neurodevelopment of the child. So much is happening. This is the period of greatest growth and pruning and everything that's happening in the brain, and it's reliant on healthy relationships. And so this is the time where if that parent is dealing with substance use, if that parent is dealing with mental health issues, if they're dealing with any type of trauma or stress in their life, if we can address that, we help the parent and we help the child. And the way to do that is to integrate those services, right? To have a developmental lens to the child, to support the parent, and frankly, to pay for it. So that's where the state has come in with a new benefit through Medi-Cal that really covers this dyadic care, to care for both the parent and the child at the same visit. Is, you might imagine, a pretty massive clinical transformation to happen. It's a rethinking of how primary care works, and really excited that here at UCSF, at San Francisco General, you guys are leading the way. So the way primary care works at the General, the Healthy Steps model, those are the types of models we want to scale throughout the state. And these slides were borrowed from Kate Margolis and the team over that works at the Center for Advancing Dyadic Care in Pediatrics, and really excited to partner with them to get this model everywhere throughout the state, so that the youth really have the ability, and their parents and caregivers have the ability to leverage this opportunity. Those are some of the clinical pieces. Just doing a quick time check here. I'm going to do a whirlwind about other aspects of this initiative, where really the ask here is to have you share this with your patients. Regardless of where you're working, there's likely something in here for you. So feel free to take these slides, follow the links, and let's see what we can do to spread the word. So maybe for those in the room, raise your hands if you've heard of Saluna and Bright Life Kids. Okay, so some yes, some no. Raise your hands if you've heard of Mirror. Okay, so almost exclusively no. So let me walk you through these really quickly. The idea in general is, as I mentioned at the top, we live in a world that is hybrid, right? We spend time on our phones. And starting on the far left, Mirror is basically a digital journaling app. And what I've heard on this planet is that there are two types of people, people who journal and people who don't. And those that journal, they love pen and paper. That tactile sensation is still like paramount and foundational and therapeutic in many respects, and that's awesome. But they also journal on their phones. And they do so with the Notes app. They do so with emails to themselves. This is a way to solve for some of the issues with that. So the way Mirror works, and you can download it right now, App Stores, Google Play, it's free, available in English and Spanish. It allows you to journal in 3 different ways. So you can type, or you can create a voice memo to yourself, or you can create a selfie video to yourself. So different ways to engage. Another piece that's really important for youth here is as you journal, you kind of start your entry by putting down your mood and your energy, and you get this word that defines maybe your starting emotion. But then the goal is to expand your vocabulary. So let's say you think you feel fine, right? The most common kind of feeling someone says when, how are you doing? Well, fine can mean tranquil. It can mean calm, but it can also mean like apathetic or bored or melancholy, right? So this kind of visually helps expand your vocabulary and think through how you're feeling as you're processing these emotions. And then some of the other aspects of it is it has some adaptive tech in the background so that you can spit out however you're feeling as incoherently as you may be at that moment in time, and it summarizes your entry back to you. So you can maybe gain some insights into the way it's organizing your own thoughts and your own reflections. And then the final piece that it does that a pad and a paper and a pen can't do is it actually can create some nudges. So if you're feeling at a state of stress, it will nudge you to the contacts in your own phone that you have self-identified as people you reach out to in times of support or in times of need. It will nudge you to Soluna. It will nudge you to 988, which is a suicide crisis lifeline. So you can avail yourself of those resources if and as necessary as you're processing things. So that's a little bit about Mirror. Soluna and Bright Life Kids are 2 other free digital platforms that now exist in the state of California that both have this like library of tools that you can use for yourself. Soluna is for those ages 13 to 25. Bright Life Kids is for the parents and the caregivers and those ages 0 to 12. I use Bright Life Kids with my own 8 and 11-year-old. Happy to tell you about my experiences with that. But so you can connect, you can get this library of tools, but you can also connect to a professional, a behavioral health professional. So let's say things aren't to the level that we're thinking of using CalMap, right? Or that issues aren't being raised in the clinic in that dyadic care model, but you still need some support. Like, is that tantrum a normal tantrum or not? On the Bright Life Kids side. On the Soluna side, I just had a horrible dinner conversation with my parents, or I'm just going through a bad breakup right now. And you can connect to a professional in Soluna as a drop-in, right? With average wait times of 3 minutes. And so you can cut down wait times. You can start that process of getting some support through that. Both also offer online communities of support. And what makes them different than a social media platform is they are pre-moderated by a human being. And so before anything gets out there, somebody is looking at that and saying, this is appropriate, let's get this out there. This is inappropriate, let's not put it out there. Or this is concerning about the person putting it out there, let's direct them to some support instead. And so those are some of the tools. Statewide, more than 400,000 youth are using these. In San Francisco, it's about 2,000 of your patients, your kids, your community who are on Soluna, and about 4,000 children and youth that are using, and their parents are using Bright Life Kids, with about 800 coaching sessions on Soluna and about 1,100 coaching sessions that have happened through Bright Life Kids. I think this is great. This is exciting. In this county, there's about more than 100,000 kids. So room to grow, right? And if you feel like this is relevant, this is important, spread the word. If you have issues with it, I want to hear about it too, because we want to make sure to continue to iterate and improve about these programs. So that's a little bit about some of the online digital supports that are out there. Another tool that's out there that kind of complements a lot of what Joanne was mentioning is a video series put on by our partners at the Child Mind Institute, talk about all these vexing parenting issues, right? Like, how do I deal with the stresses? How do I have that conversation with my child to become, I don't know, a thoughtful person who creates these safe, stable, nurturing relationships with them? They're 6 to 7 minutes long, each video, viewed by tens of thousands of individuals throughout California and really the world. I personally use them as movie trailers. On Fridays at my home, we do Netflix or we stream some movies. And before that, I put on one of these just to start some conversations at home. And sometimes I'm met with groans. Other time, you get some really great, interesting conversations that happen as a result of it. So however you feel that it's appropriate in your own lives, if you've got videos that are playing in your clinic, in your hospital rooms, you can consider adding these to the library there. If you need smart phrases, right? If you need ways to incorporate this into your clinical settings, these are ways you can consider putting this after every asthma visit, right? After every other visit, you can say like life can be intense. And if you need some support in addition to that, you can use these platforms and apps. So different ways to think about incorporating them into your clinical encounters, no matter what your specialty is or what you focus on. I'll spend just a brief moment on the idea that all of these supports, all of these tools are great if people feel empowered enough to use them, right? So we need to change the conversation around mental health in California, on this planet, and reduce the stigma and increase our literacy around these concepts. We have a number of different campaigns. You'll see billboards and messages around that with that goal in mind. So this one is called Take Space to Pause. And the idea behind it is let's just get some vocabulary out there to young people, ages 13 to 17 for the most part, about their stress response system, right? In many great videos. I think for the purposes of time, we'll skip some of the videos, but this particular one by this coach, her name is Jackie, she talks about the idea of body, thoughts, and connections, right? So when my stress is bubbling over, how do I use my body to exercise, to get it out? How do I reframe or think about my thoughts? And what type of social connections are important there? So really kind of simple language, ways to socialize this messaging. Stigma is culturally nuanced, right? It looks different in every community. So we've also partnered with many different community organizations for them to take this message and to customize it to their own language, to their own culture and their own customs. This is one of my favorites. It's a partnership with the Indian Health Council down in Southern California. They trained these youth on photography, on modeling, on language, on communications, and then they created this campaign of just centering culture and centering the idea that we can thrive together. They came up with the tagline and they're spreading it throughout both their community and tribal communities up and down the state. So if you work with a particular population, there are customized local campaigns that we're happy to connect you with and spread the word. Another message that we really want to get out there is the concept of adverse childhood experiences, ACEs, right? Raise your hands in this room if you've heard about them. It's so great to see. Keep your hands up. Now, keep them, and for those online, I think like 95%, 99% of folks' hands are raised in the room. Keep them up if you think your patients have heard of ACEs. Yeah, so now we're at like maybe 20% of the room. That's what this is about, right? This is about getting out of the clinics, getting it out of the libraries, and getting it onto the streets. And the idea, the way to do that is to have youth talk to youth and share their own messages, share their own ways of talking about this. And that's why you can see the number of beautiful faces here of real Californians, many of whom I've met, some of whom work for UCSF, actually. Sitare is a great partner, works with Ondequo and does amazing work. That are sharing their own stories. They're being vulnerable to the public to really raise awareness about adversity in childhood and the impacts it can have and the ways we can mitigate it. So the ways we can live beyond it. There's also a patient guide. And so you can think in a clinical setting, as you're screening, as you're doing some of this work, you can share out evidence-based information. And then finally, we have a campaign on suicide prevention. And it's called Never a Bother. And it's to address that concept of burden, right? That a lot of people on this planet feel like they're a burden to others. And so we want to get the message out. This is one that youth developed, that they are never a bother. And you can see the language on here is meant to increase knowledge and awareness. So what do I do if I'm worried about something my friend posted on social media? Like, how do I think through that actual scenario? And there's a lot of material and information and education around these types of topics. Very fortunate to partner with Megan the Stallion to share some of those messages. So I'll take a moment because you'll hear it better from her than from me.
I know when you feel like you're sad, you start using like a lot of self-hate language and you start feeling like it's me, I'm the problem, nobody cares, nobody likes me anyway. Like you just start feeling like it's all you and there's nothing that can be done about it. And you don't want to burden anybody else with your problems. But I had to learn that it's not that you're a burden. Like if you need to ask for help, that's just genuinely what you need to do. And the people around you need to make you feel validated in how you feel. One of the resources that you could use is 988, and it's like professionals that you could talk to. And then there's another one called Teen Line, and I didn't know about this, but it's teens that are volunteering their time to talk to other teens. Like it's people who know exactly what you're going through. It took me a long time to be comfortable talking about my mental health, because another thing in the Black and brown community is don't get nowhere telling your business. My grandma used to tell me not to tell people her business. So that's how I grew up. That's what I was thinking. I was like, oh, I can't talk to no stranger and tell them my business. I feel like we need more Black and brown advocates for mental health. Now I feel like I can relate to you and it makes my wall come down even more. And now I'm more able to receive the help that you're giving me. I'm able to receive the words that you're saying. You're making me feel feelings that I don't think, somebody who is not like me would make me feel. Asking for help doesn't make me weak. Asking for help actually built my strength. Asking for help or going to get the help gave me the tools to be stronger. So I just definitely want to talk to the hotties and let them know it's okay to ask for help. Check up on your friends, like check up on your family. You don't know what's going on. So you should ask rather than just assuming, oh, you're busy or you don't want to hang out. Maybe you're acting different because you're feeling away. And is it something I can help with? I do care about you. I do hear you. I do love you. And you do matter. Hotties, you are never a bother.
She says it better than I ever could. So, yeah. If any of this resonates with you, we got handouts, we got social media handles, we got flyers. If you want your clinic to get a poster makeover, come talk to us. Smart phrases, all of these pieces, because it's only going to get as far as we all collectively engage. I can tell you by the ways we measure the campaigns, the 3 campaigns I brought up have reached 2.3 billion impressions. So that's exciting to see it's resonating and conversation starters are happening, but I think we still have a long way to go. So, here's a website or a link or a place where you can go to check out more, but I'm also happy to connect with you all personally. And then this is the last slide here, which is just to say, I think we're moving in the right direction. There's a lot more to be done here, but on the left is a question we ask year after year to high school students, which is, have you felt so sad that you have stopped doing regular activities for a period of 2 weeks or more in the past 12 months, right? So pretty similar to our definition of clinical depression. And you can see from the heights of the pandemic, things are moving in the right direction. Still more to do, absolutely. But I think it's a result of certainly some of the state investments, but the conversations we're having as a society and some of the resources that hopefully people are now availing themselves of. And the second piece is around suicidal ideation. So have you seriously considered suicide in the past 12 months? And you can see we are now, for the first time in a long time, reaching the single digits in some grade levels, but still much more to be done. So thank you for your attention. I know there's a lot going on both clinically and in the world right now, and just really appreciate your time and your focus on this topic. Happy to take questions if there's time.
you guys so much. We do have a mic, so I can go around, but I'm going to ask the first question. Well, I go around. So I was interested in the reimbursement model for the people who are providing the advice. Is there some FTE or is there? I have a dual question actually. So that was one part. So that was one piece, and then the second piece is around. So you have like the follow up on the provider side, but what about the follow up on the patient side? Like, and particularly, I noticed one of the quotes was about suicide, suicidal ideation. And do you have a sense of how you're impacting mental health overall with these programs?
So those are great questions. First one about the reimbursement. There's a much clearer path forward for the primary care provider to be able to bill and get reimbursed than for the consultant. There are medical legal reasons and financial reasons why it's not easy to go the billing route for sustainability. What older programs have done, other CPAPs across the country, they've worked out a reimbursement model where the major payers in the state, including Medicaid, will kind of divide up the costs and each contribute based on the percentage of kids they see. And that just ends up being way more efficient and way more sustainable. And so this is what we're hoping maybe can be worked out over the long term, get the payers to kind of all pitch in for this service. Now for the patient outcomes, would love to see more research to be able to be done on the impact, like what actually happens at the level of the patient. I think that involves like a whole other level of kind of, I don't know, all the researchers in the room would love to hear your thoughts about how we get to that. Just anecdotally, like what the people will come back and say, it's like, this saved my kid's life. This saved my patient's life. That care coordination consult saved my patient's life because they got that DBT or they got that therapy or they got into this service or we were able to start this medication. Kid stopped having panic attacks and started going to school, So there's a lot of anecdotal stuff that comes back, but then we need some systematic way of being able to track those patient level outcomes. It's a great question.
Yeah, I mean, I do think there's a lot of things like digital reminders where they could potentially just click on and fill out a little red cap survey or something. I mean, it wouldn't be necessarily systematic. You'd have to look at your response rates and things like that. But, maybe something's better than nothing. Nikki's probably a better person to comment on this than I am. But anyway, sorry, I went away.
Thank you both for your work on this. This is so exciting. Having come out to UCSF 35 years ago for internship and being here as a provider for all these years, it's mind-blowing to finally see all of these things being rolling out. And I've personally used them and I really applaud your efforts. So 2 questions. One, recognizing that adolescents so rarely come through the clinical doors, I'm wondering what kinds of campaigns you're doing through schools and other things to get the word out specifically about Soluna. And also, if you have any knowledge about whether any kind of inpatient services for rehabilitation treatment for adolescents are available for the Medicaid population, because that's something that we've really struck out on so far through the patient population at the general.
Thanks for the questions, Meg, and great to see you. On the aspect of schools, so much is happening with schools in so many different ways. So as a quick kind of a sense of the different ways that we're approaching working with those, and primarily in the K-12 space, but when I refer to schools, I'm also talking about childcares and higher ed also, is in part, there's this concept called social and emotional learning, right? It's this idea that you can actually teach resilience and you can teach it while you're teaching math, while you're teaching PE. So it's a framework of how you structure your day and the pedagogy. And we're working with all 58 counties to scale that type of teaching that's happening. An example my kids are going through is they're writing down kind of when they're in the red zone and what it takes for them to get into the green zone emotionally after a specific activity. So there's ways that you can do this in a developmentally appropriate manner also with their language. That's one of the aspects. Another aspect is we're trying to change campus culture by teaching teachers a trauma-informed approach to relationships. So this is an idea of teaching them ACEs, teaching them the idea of stress. Like you can have positive stress, you can have tolerable stress, you can have toxic stress, right? And what that looks like in any given kid. It can be internalizing or externalizing behaviors also. And then another component is we're linking schools to care. And basically finding pathways for health plans to really reimburse the care that's being provided by the school counselor, by the school nurse, by the community organizations that partner with schools for care to happen there. So those are some of the more specific ways that we're working with schools. And through all of those ways, the platforms like the campaigns, Saluna, Bright Life Kids, all of these campaigns are also being promulgated and demonstrated in all schools.
I also wanted to add that one of our Project Echoes is specifically for schools. So at CalMap, so we have our primary care echo, but we also have our school echo. So it's not just it's school counselors, teachers, anybody who comes in with like specific sort of behavioral questions about, so it's all teach, all learn. Let's talk about our patients, our students in this case together and learn together.
So we have one online question. I know there's others here, but I'll do the online one real quick and then we can go on because it's already one. But the membership of the number of youth this is from Curtis Chan, excuse me. The number of youth who are using mental health support through the Soluna app is indeed mind-blowing excellent. What's the plan for measuring specific strategies for engagement in other counties?
Yeah, so Curtis, happy to tell you more about what's happening in the counties in which you work. We have data disaggregated by counties, so happy to share that out. The other pieces I can tell you off the top is that people are using it in all 58 counties. More than half, so more than 50%, are coming from HPI quartiles, Healthy Places Index quartiles that are 1 and 2, so lower socioeconomic areas. And for more than half, this is their first time ever receiving professional behavioral health support. So in the sense, that's the model those are the goals we're trying to accomplish, and seeing some really great uptake on that.
One more live question, or we're already over. Okay, great. Thank you guys so much.